Dr. Adib Chaudhary. I'm secondary resident in Purdue Medical College. I'm presenting analysis of reasons for pending and rejected Pradhan Mantri Jan Arogya Yojana, that is PMJ claims, at secondary and tertiary care public health institutes, PHIs, in a district of Western India. India had come up with the most ambitious health scheme ever, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, ABPMJ, a government-sponsored health insurance scheme in 2018. There are all three online systems: beneficiary identification system, BIS, for beneficiary enrollment, transaction management system, TMS, for claim processing, and central grievance redressal and management system. Gujarat had approximately 1800 PHIs out of 2600 M-panel PMJ hospitals, but the claim money of PHIs was only 200 crore, excluding the Apex hospital, out of the total 4000 crore in the financial year 23-24. Government of Gujarat had outsourced beneficiary facilitation agency at district level, which contained some Pradhan Mantri Arogya Mitra PMEMs, which is discontinued now, and PHIs are hiring the PMEMs on their own now. Mehsana district has enrolled target-wise highest PMJ cards in Gujarat state till July 24, and then only 8.61% in beneficiary were pending for enrollment in BIS, whereas the state pendency was 25%. So there should have been list issued at the level of BIs, but most at the TMS for many claims to be pending or rejected. So the objective of this study was to know the proportion and to analyze the reasons of rejected PMJ claims, to know the proportion and to analyze the reasons for pending PMJ claims, and to recommend possible solutions for secondary and tertiary care PHIs. It was a retrospective analytical observational study in a district hospital DH Mehsana and a community health center CHC Langanaj in Mehsana district in August 24 of all PMJ claims initiated in 6 months, that is from January to June 24. This study included one tertiary care PHI, a hospital, and a secondary care PHI, a health center, to get a comprehensive picture of health system. It included DH Mehsana and CHC Langanaj to purposely sampling, because these PHIs were the highest claiming in those categories of DH in the first 6 months of 24 and CHC in the financial year 23-24 in the whole of the state. It got access to the line list of all the claims initiated in this study period, along with the reasons for rejection and pendency. Data collection were made through the MS Excel 2019. Before going to the results, I would like to go through the TMS workflow. So once the patient will come to the hospital, it will get registered by the PMM. Then the patient will get diagnosed and will get an admission in the hospital. Then the medical coordinator, that is the medical side doctor, will submit this claim in the TMS to the insurance side, that is called the pre-auth panel doctor, in short PPD. The Medico can cancel the claim at that level, but if it processes, then PPD can approve, reject, and give some query and make it pending also. Once it is approved at the level of PPD, then patient will get treatment, medical or surgical, and then patient will discharge. Again, after discharge, the medical coordinator will submit the claim to the claim processing doctor, that is called CPD. Again, CPD can approve, reject, and make it pending with the queries, and then it goes to the paid file. So let us go to the results proportion wise and reasons wise. So let us go for the proportions. The numbers of claim: 54% were paid, whereas 27% were PPD rejected, 9% were PPD cancelled, 8% were CPD rejected, and 2% were pending in CHC. In DH, it was 69% were paid, 5% were PPD rejected, 8% were PPD cancelled, 4% were PPD approved, 3% were CPD rejected, and 11% were pending. If you go through the money involved in those claims, only 59% in case of CSC and 60% in case of DH was paid, whereas the 40% were either cancelled, pending, or rejected. So just summarizing the results in case of proportion, so it is 33% out of the 92% process claim were either pending or rejected at CHC, whereas 28% out of the 88% process claim in case of DH were either pending or rejected. Let us go to the reasons for that. For PPD rejection, the most common reasons at CSC were document submission pending, false package selection, investigation, delayed or no query resolved, among others. At DH, false package selection, document submission pending, duplication, delayed or no query resolved, among others, were the common reasons. For CPD rejection, the most common reason at CSC were pending investigation sheet, treatment sheet, vital chart, patient photograph, among others. Whereas at the level of DH, patient photograph, discharge summary, OT note, culture sensitivity, and histopatho examination were common reasons, among others. For pendency, the common reasons at CSC were patient photograph, ARV dates, USG report, pendency, whereas in case of DH, it was patient photograph, discharge summary, dialysis photo, treatment sheet, culture sensitivity, histopatho reports, and OT notes, among the others. So just summarizing the reasons for that, we can see that at the level of PPD, both CSC and DH has somewhat common reasons. At CSC, PPD rejection and CPD rejection reasons are common, and at DH, the CPD rejected and the pendency reasons were more or less common. So I would like to conclude this result as around 8 to 9% were cancelled by the hospital itself. Around 1/3 claim money were either rejected or pending, and at PPD level there was false package selection, duplication mainly at DH, and pending document for diagnosis were common reasons. At CSC, the pending investigation was the most common reason, and at DH, pending documents of treatment like patient photograph, discharge summary, OT note, culture sensitivity, histopathology report was the most common reason for CPD rejection and pendency. So based on this conclusion, I would like to recommend there should be a package-specific checklist listing all the necessary documents should be attached with the case file itself. Also, there should be provision of standard treatment guidelines to all common packages at the department level, whatever they are claiming for, and along with that, it's a regular rechecking, monitoring, and review system should be developed. And specific recommendation at the level of PPD would be there should be a training and sensitization session to all PMMs and medical coordinator by the insurance company and state health agency. At CSC should be equipped with the necessary lab services, or it should be made available through the tie-ups. And DH should be equipped with a structured dedicated PMJ claim team, which comprises of medical and paramedical team, along with the financial staff. Assigned person should be there for specific document submission. It should work as a link between hospital staff and PMMs to solve all these queries. Swasthasya swasthya rakshanam aturasya vikara prasmanam, as stated in Charak Sanhita. The first part, swasthasya swasthya rakshanam, means the one who is healthy should be kept healthy. That is the first part of Ayushman Bharat, Ayushman Arogya Mandir. And aturasya vikara prasmanam, that is second part, means the one who is ill should be managed or cured. That is the second part of Ayushman Bharat, that is PMJ. As stated by one PMMs in Mehsana, તમે અમારી મુશ્કેલીઓ સાંભળનારા પ્રથમ વ્યક્તિ છો. થેન્ક યુ.